So, for centuries, society has been completely obsessed with this concept of a quote-unquote loose vagina.
Yeah, it's a very persistent cultural thing.
Right. And it's basically been weaponized, as a way to judge and police a woman's sexual history. The myth is basically that a large partner, or like having frequent penetrative sex over the years, will permanently stretch out the vaginal canal.
Right, which is just wild because when you put that trope under the microscope of medical science, I mean, the anatomy behaves entirely differently than what the myth suggests.
It is there.
It's just this profound disconnect between so-called common knowledge and, well, biological reality. These misunderstandings just get repeated so often across generations that they basically calcify into facts.
Especially regarding reproductive health. So to figure out exactly how wide this gap is between the myth and the medical reality, we are pulling from a massive stack of sources today for this deep dive.
Oh yeah, we've got a lot to get through.
We really do. We're looking at medical databases, so the Cleveland Clinic, the Mayo Clinic, the FDA.
We also have clinical perspectives from physical therapy groups, right? Like Origin and the Women's Health Clinic.
Yeah, and reproductive health data from Clue and Ann. We're even examining arguments from cosmetic gynecologists just to see how this is being treated, on the ground right now.
It's a really comprehensive look.
Okay, let's unpack this. We are going to completely debunk the mechanical myths, explore what actually alters vaginal elasticity, because, significant changes do occur, just not the ones we're warned about.
Right, the real changes are much more complex.
Exactly. And we want to help you, the listener, understand the really fascinating engineering of your own anatomy.
The mechanics are really the best place to start here. Because if we tackle that core question directly, does penetrative sex, particularly with a large partner, cause permanent looseness?
Yeah.
The scientific consensus is an absolute no.
Zero permanent change.
Exactly zero. The dimensions of the vaginal canal remain exactly the same whether someone has had penetrative sex once, 1,000 times, or never.
Wait, so if we're dealing with a physical tube,
Right.
and a large object passes through it repeatedly, everyday logic would suggest some level of wear and tear.
You would think so, yeah.
Why doesn't it permanently stretch out? Like, what is happening structurally that stops that degradation?
Well, it really comes down to the specialized engineering of the vaginal walls. I mean, the vagina is not a rigid pipe.
Right.
And it's not a simple balloon either.
Yeah.
It's this highly dynamic fibromuscular tube, and it's composed of 3 distinct layers.
Okay, 3 layers.
Yeah, so you have the innermost mucosal layer, a middle smooth muscle layer, and then an outermost fibrous layer called the adventitia.
And that outer one is packed with collagen, right?
Exactly, dense collagen for overarching structural support.
But looking at the literature on that innermost layer, the mucosa, it seems like the key isn't that the tissue is just stretching and thinning out. It's built more like an accordion.
That's a great way to put it, yeah.
Because it's packed with these transverse ridges and folds called rugae. So the canal isn't just this hollow cavern waiting to be filled. When it's in its resting state, it collapses in on itself into like a W or an H shape.
Right. And what's fascinating here is that those rugae are specifically designed by nature for temporary extreme expansion.
Not permanent, but temporary.
Exactly. They allow the tube to expand dramatically, like voluminously enough for an entire baby to pass through during childbirth.
Which is mind-blowing.
It really is.
Yeah.
And then, crucially, those accordion folds allow the tissue to snap right back to its original resting state, where it can hold something as slim as a tampon firmly in place.
So the middle layer, the smooth muscle, that clearly plays a huge role in the rebounding action too, right?
Yeah.
Because smooth muscle is involuntary. It's governed by the autonomic nervous system.
Yes, exactly. It maintains what the medical literature calls intrinsic compliance.
Intrinsic compliance.
Yeah, which basically means it holds a baseline resting tone at all times. It's actively applying consistent pressure inward. That's why things don't just fall out.
It's an active muscular system.
Right. It's never just passively waiting.
Which entirely flips the narrative on what a feeling of looseness during intimacy actually means. Because we're culturally conditioned to think that feeling expansive during sex is a mechanical failure of the muscle.
I think it's worn out.
Yeah, exactly, like being worn out. But biologically, during sexual arousal, the body releases this signaling molecule called nitric oxide, and that causes the smooth muscles of the vagina to actively relax.
It literally makes space. The canal naturally dilates and lengthens in response to arousal. This physiological process is actually called vaginal tenting.
So feeling loose, or expansive during sex is literally just a sign of proper healthy arousal.
Yeah, it's the tissue performing exactly as designed.
And on the flip side of that, if the vaginal muscles feel extremely quote-unquote tight during penetration, that's often not a sign of like some idealized youthful anatomy.
Not at all. Extreme tightness can actually indicate tension, a lack of adequate arousal, psychological fear, or even a specific medical condition known as vaginismus.
Right, with a muscle spasm.
Exactly. Vaginismus is when the pelvic muscles involuntarily spasm and contract, making penetration incredibly painful or even impossible. So, extreme tightness is frequently a symptom of dysfunction, not health.
So if we think of it like a brand new hair tie versus an old one, sex doesn't permanently stretch out the elastic. The elastic is built to rebound every single time.
It doesn't wear out from use. The origin of the myth simply isn't rooted in biology at all.
It's rooted in sexism.
Yeah, it stems from historical attempts to judge and control women. You see this manifesting in really harmful, unscientific practices globally.
The sources specifically highlight the two-finger virginity test.
Yes, which is a practice historically used in various regions, including parts of India, where an examiner manually checks vaginal laxity to supposedly determine if a woman is a virgin.
Which is medically impossible to determine by gauging muscle tone.
Completely baseless. The resting tone of a woman's pelvic muscles has zero correlation to her sexual history.
But, okay, if the accordion folds snap back after sex, we still have to account for the physical reality that a lot of patients do go to their doctors reporting a genuine feeling of laxity.
Yeah, absolutely.
So if it's not a partner causing it, something else must be failing to snap back.
Right, and to understand that, we have to look slightly beyond the vaginal canal itself. We need to look at the structural hammock holding the entire system up.
The pelvic floor muscles?
Exactly. We have to talk about the pelvic floor.
Which is a term that gets thrown around constantly in wellness circles, right?
Mm-hmm.
But mechanically, it is doing some really heavy lifting. It's a group of muscles, primarily the levator ani muscles.
They attach to your pelvic bones and wrap completely around the lower portion of the vagina, the urethra, and the rectum.
So they function as this supportive muscular sling.
Yeah, holding all your pelvic organs up against the constant downward pull of gravity. So when a woman feels loose, it's rarely that the accordion folds of the vagina have smoothed out from intimacy.
It's the hammock.
Right, it's that the muscular hammock supporting the whole structure has been compromised. And the most significant event that compromises that hammock is vaginal childbirth.
Because during a vaginal delivery, that baby isn't just passing through the stretchy mucosal folds, it has to pass through a specific opening in that muscular pelvic floor.
Called the levator hiatus, yeah. And the mechanical stretch required to achieve that is staggering.
I read the numbers, it's insane.
Biomechanically, the levator ani muscles must stretch anywhere from 1.5 to over 3 times their normal resting length just to allow a baby's head to crown.
Wait, stretching a muscle to 3 times its length, does it just bounce back the way the rugae do?
Well, for many women, yes, the muscle fibers do recover their tone over time, but for about 10 to 30% of women, the stretch is simply too much.
The fibers just give out.
Yeah, they become permanently overstretched, or in severe cases, they literally tear off the pelvic bone.
Oh, wow. And unlike a surface cut, like a standard perineal tear that a doctor could just stitch up, if a muscle detaches from a bone deep inside the pelvis, it doesn't just refuse itself, does it?
No, it doesn't. This specific trauma is called a levator avulsion, and the sources point out very clear risk factors for this injury.
Like it being a first birth.
Right. It's most common during a first vaginal birth. Older maternal age is a factor too, as tissues naturally become less compliant and stretchy as we age. Large babies and prolonged pushing also contribute.
But the literature emphasizes one intervention above all others as a massive risk factor, and that's the use of forceps.
Forceps drastically increase the amount of force applied. It increases the width of the stretch and the speed at which those levator muscles are pulled.
So that rapid, forceful extension basically vastly increases the likelihood of the muscle tearing off the bone rather than just stretching.
Exactly. And this highlights a pretty harsh truth reported by Birth Trauma Australia. Once that deep levator muscle is pulled off the bone, imaging actually shows it shrinks and retracts toward the back passage.
Wow. So it does not reattach on its own.
No, you permanently lose a significant section of your support hammock. This weakens the entire pelvic floor by about 1/3 and drastically enlarges that opening, the levator hiatus.
Which sets the stage for pelvic organ prolapse, right?
Yes, because the structural floor has dropped out. Organs like the bladder or the uterus slowly succumb to gravity and literally start to bulge down into the vaginal canal.
The sources describe the sensation of prolapse quite vividly. They say it feels like a dry tampon is constantly hanging out or experiencing this heavy, dragging bulge in the pelvis,
Especially after standing for long periods or lifting heavy objects, it frequently leads to stress urinary incontinence as well.
which is leaking urine when you cough or jump or laugh.
Right. So, when a woman experiences a profound feeling of looseness or a distinct lack of friction during intimacy after having a child, it's very often linked to this invisible deep muscle trauma.
Not the vaginal tissue itself wearing out. Okay, so that covers the mechanics of childbirth injuries. But there are individuals who have never been pregnant who report this identical feeling of profound laxity.
That's true.
So to understand laxity without mechanical trauma, we have to look away from the muscles and look at the cellular environment.
And if we connect this to the bigger picture, this brings us to a fundamental shift in the actual tissue of the vagina itself, driven by the clock and hormonal changes.
Right. It all revolves around one crucial hormone, which is estrogen.
Estrogen is essentially the architect of those stretchy rugae we discussed. The vaginal tissue is entirely dependent on it for structural integrity.
So during the reproductive years, high estrogen levels keep the vaginal lining thick and plump and moist.
But when menopause hits, or during prolonged breastfeeding, or following treatments like chemotherapy or ovary removal, estrogen levels plummet.
And that sudden drop triggers a cascade of physiological changes known as genitourinary syndrome of menopause, or GSM.
Yes. Reading the symptom list for GSM, which was previously known as vaginal atrophy, it describes a very real physical breakdown.
The tissue literally becomes thinner and paler.
It loses those rugae, so the accordion folds smooth out permanently, which can actually make the canal narrower and shorter.
And the tissue becomes so fragile that it can easily tear and bleed during regular intercourse.
It is a profound structural change at the cellular level. Just below the surface of the vaginal skin lies connective tissue full of cells called fibroblasts.
Which are basically factories responsible for producing collagen.
Exactly. They provide the tissue elasticity. But postmenopause, deprived of estrogen, these fibroblasts essentially go to sleep. They become dormant fibrocytes.
So without estrogen, the tissue literally stops producing its own structural support. Without fresh collagen, the existing fibers fuse together and you lose that vital elasticity.
And the domino effect goes even further. It alters the entire microscopic ecosystem of the vagina.
Because in a healthy estrogen-rich vagina, the surface cells are constantly turning over and shedding. And as they shed, they release a complex sugar called glycogen.
Right. And this glycogen serves as the primary food source for lactobacilli, which are the dominant healthy bacteria in the vaginal microbiome.
And those lactobacilli produce lactic acid, keeping the vaginal pH low and acidic.
Which creates an environment completely hostile to infections.
But when estrogen drops, the lining gets so thin that cell turnover just plummets.
Less cellular shedding means significantly less glycogen. Without their primary food source, the beneficial lactobacilli literally starve and die off.
Which means the lactic acid disappears and the pH of the vagina actually rises. It becomes less acidic, which essentially rolls out the red carpet for harmful bacteria, like E. coli, to colonize the area.
This perfectly explains why individuals suffering from GSM don't merely experience painful sex and dryness. They are frequently plagued by recurrent urinary tract infections. The acidic protective barrier is simply gone.
It's really like a localized drought in a garden.
That's a perfect analogy.
I mean, it isn't just the soil cracks and dries out, though it does. The entire local ecosystem changes. The beneficial insects leave, invasive weeds take over, and the roots of the remaining plants lose their grip.
The urinary and reproductive systems are deeply interconnected.
Yeah.
That ecosystem perspective highlights why GSM causes such profound discomfort. It isn't just a sexual issue. It affects everything from intimacy to basic daily functions like sitting comfortably and urinating without pain.
So if someone is dealing with either the broken muscular hammock from a levator avulsion after childbirth or the dormant collagen and altered ecosystem from GSM during menopause, what is the clinical consensus on treating it?
Well, the interesting thing is there really isn't one unified consensus.
Yeah, looking closely at the literature, the medical community is completely fractured on this issue. Let's lay out the contrasting solutions here because they are very different.
We encounter a very sharp divide.
On one side, we have the perspective of cosmetic gynecology. We reviewed the writings of Dr. Michael Reed, who is a board-certified OBGYN and cosmetic gynecologist.
Right. And he argues that the broader medical establishment largely ignores this issue, despite claiming that vaginal laxity affects up to 75% of women over their lifetime.
Dr. Reed's position asserts that conservative non-surgical treatments are largely ineffective for significant laxity.
He specifically states that Kegel exercises, which are the standard physical therapy recommendation, are only truly helpful for about 10 to 12% of the women who diligently practice them,
So his proposed solution is surgical. He advocates for vaginoplasty.
which he provocatively refers to as the women's Viagra.
Yeah. He argues that surgery is necessary to recreate the downward angle of pleasure that exists prior to childbirth, specifically aiming to increase friction during penetrative sex.
He even quotes the phrase tight is right, asserting that surgically decreasing the internal and external diameters of the vagina is the definitive path to restoring sexual satisfaction.
So that represents the surgical cosmetic viewpoint.
Mhm.
But if we examine the opposing side of the debate, representing clinical guidelines and physical therapy, we see a starkly different approach.
Very different. Sources like Origin Physical Therapy, the Cleveland Clinic, and Birth Trauma Australia strongly caution against surgical interventions for laxity unless there is a severe medically diagnosed pelvic organ prolapse.
The physical therapy side argues that surgeries designed purely to quote-unquote tighten the vagina can be incredibly counterproductive.
They point out that cutting into that delicate tissue to reduce the diameter inevitably creates rigid scar tissue. And scar tissue does not possess rugae. It doesn't stretch or rebound.
So instead of restoring a useful elastic feel, surgical tightening can actually result in severe chronic pain during intimacy due to that rigid scarring.
Right. They specifically highlight historical practices like the husband stitch, which was an extra medically unnecessary stitch given to the perineum after childbirth to tighten the vaginal opening.
Which they describe as outdated malpractice that frequently causes long-term pain and dysfunction.
Exactly. So instead of the scalpel, these sources champion functional rehabilitation. For childbirth injuries and muscular weakness, they advocate for pelvic floor physical therapy.
Which involves working with a specialist to strengthen the remaining weak muscles through targeted exercises. But just as importantly, learning how to relax muscles that might be too tense and just mimicking tightness.
And for the menopausal structural changes, the GSM clinical guidelines lean heavily on restoring the local environment.
Which involves using topical estrogen creams or rings applied directly in the vagina.
Oh, yes. Localized estrogen wakes up those dormant fibroblasts, thickens the tissue, and restores the glycogen needed to feed the lactobacilli.
They also recommend non-hormonal options, right? Like targeted hyaluronic acid moisturizers and the use of vaginal dilators combined with physical therapy to safely stretch the thinning tissue over time without causing microscopic tears.
Right. There are multiple non-surgical tools.
So what does this all mean? We have a direct collision between cosmetic surgeons telling women that surgery is the only effective fix for the friction lost during childbirth, and physical therapists warning that surgery might ruin sexual function with scar tissue.
Offering a path of functional rehab and hormone restoration instead.
Right. It really underscores how critical it is for patients to understand the underlying mechanical and chemical reality of their own bodies.
Exactly. Whether a patient's issue is muscular from childbirth or hormonal from menopause, understanding the specific cause allows them to critically evaluate the vastly different treatments they might be offered in a clinical setting.
You have to be an informed advocate for your own body. So we set out today to answer if a large partner or frequent sex permanently stretches out the vagina.
And we can confidently say that the myth is busted.
Totally busted.
The vaginal tissue is dynamic and incredibly resilient. Penetrative sex does not permanently alter the anatomy.
However, significant life events like childbirth, which can traumatize the pelvic floor hammock, and hormonal shifts like menopause, which fundamentally alter the cellular structure, absolutely do change the landscape.
They absolutely do.
Understanding this science is deeply empowering. For you, the listener, knowing these mechanics strips away centuries of cultural shame. You are not too loose because of your sexual history.
No, not at all.
And you do not need to suffer in silence if you are experiencing painful tightness, chronic UTIs, or a loss of sensation. Understanding the distinct difference between a deep muscle injury and a hormonal ecosystem shift empowers you to seek the exact right help.
Whether that means booking a session with a pelvic floor physical therapist to rebuild that supportive hammock, or talking to a specialist about localized estrogen to heal your vaginal ecosystem.
But this raises an important question, though, as we look to the future of treatment. Because we learned today that a lack of estrogen reduces the glycogen that feeds the healthy, lactobacilli bacteria.
Right, which directly leads to structural damage, rising pH, and painful infections.
The localized drought in the garden.
Exactly. So could the future of treating physical vaginal laxity and atrophy actually lie not in surgery, and perhaps not even just in physical therapy or hormone replacement alone, but in bioengineering the vaginal microbiome? Right. Could specialized, highly targeted probiotic treatments one day replace estrogen creams or scalpels, actively maintaining that microscopic bacterial ecosystem to keep pelvic tissues youthful, elastic, and structurally sound from the inside out?
Imagine a future where we treat the elasticity of human tissue by tending to the bacteria that live on its surface. It just goes to show how much we are still discovering about the profound interconnectedness of the human body once we push past the outdated cultural myths.
It's an exciting frontier.
It really is. Thank you for joining us on this deep dive. Keep asking hard questions, keep challenging the anatomical narratives you've been handed, and above all, stay curious.